always, if you wouldn't mind dropping your name and affiliation in the chat, that way we can document your attendance for our roll call. Again, this is just for our formally selected representatives. If you drop your name in the chat, and if you're joining us by phone, feel free to come off mute and introduce yourself as well. Otherwise, we'll get started right at 4:32. Great. Welcome, Jessica. Hi, Dave. Hey, Dr. Freeman. Shayla, 2 calls with us today. Thank you so much for your time. I appreciate it. Good to see you all. And for those that want to come on camera, we always welcome you to do so for our discussion, but no pressure if that isn't doable right now. Hey, Dr. McGrew. Hey, Karen. Great. All right, we are going to go ahead and get started here today. So as always, I'm really looking forward to this time together. We will be focused today on our care coordination model and program. Really looking forward to a range of special guests sharing a little bit more about their hard work behind the scenes to help us think through this program. Matt Burdick, who is one of our behavioral health policy experts on our team, will be presenting, as well as Deborah Harberger from our Yukon Innovations Institute team that's been helping us out. And then I'm really excited for a team of folks that have been working very hard on our Youth and Family Summit, Jessica, Carly, and Brenna, to share a bit more about their work in preparation for this as well. So with that, again, reminder for representatives, please add your name to the chat. We have confirmed to have reached quorum here, so we are going to go ahead and get started. So as always, my name is Ann Jensen. I am the Medicaid administrator here at Nevada Medicaid, and I'll be starting with some follow-ups from our July working group. First, on the fun side, I'm really excited to share our top 3 names that were submitted and narrowed down from a list for our specialty care plan. So again, we asked folks to provide suggestions for a name that feels really approachable and creative and really aligns with our overall mission of the specialty plan. We recognize that CBHT is not the catchiest acronym, and we want to come up with a name that really sticks. And so as part of our overall marketing and thinking about how to communicate this plan, we want to start with a new name for it. So we received a host of suggestions from our working group representatives and our internal state staff. And these are the top 3 that we've narrowed down, and we'd love your vote. So anyone is able to vote on this. My team will drop a link to this voting survey in the chat here. And we welcome you to select your favorite. And if there's another one you're still interested in, shoot us an email and we'd love to hear it. Again, those 3 names are Nevada WISH, which stands for Wraparound Intensive Supports for Healing, which is very timely to our conversation today on care coordination. Pathways Plan, which with a focus on creating pathways to support. And lastly, the Silver State Kids Plan, connecting Nevada's kids to the care they deserve at home, in school, and beyond. So I want to thank all those that took some time to put their creative thinking caps on and submit names. We're really excited to continue this work. And again, would appreciate your vote if you're interested by Friday, August 29th. With that, on the note of our specialty plan, I just want to give a few updates related to our public feedback. So back in May, we issued a request for feedback on our website to inform the specialty plan design. And the goal is really to get feedback from providers and from managed care partners, and especially from youth and family members on how best we can design this plan. And there were some pretty comprehensive questions. For those that found that on our website and answered, you'll know. Those areas we asked about were case management, the care coordination approach, benefit design, provider network, cross-system collaboration, and contract design safeguards. So I want to share that we received 26 submissions from the following groups here that you'll see listed. I want to thank everyone. Some of those submissions were fairly lengthy, and we have taken a lot of time, and all the folks on our team that are working on this contract have individually read each and every one of these responses. And that is informing the decisions that we are making now and will be making over the coming year to really help think through the right way to design this plan. So I want to thank you again for taking that time, and I want to share a few key themes that we learned. So first, there was very strong support for wraparound and peer support as part of that care coordination model. A lot of emphasis on lived experience of these staff members providing those care coordination services, and particularly, of course, within peer support on helping our families navigate the system. I think we all feel very deeply how complex and fragmented the system is. And so a lot of great feedback about how the specialty plan can support that by really drawing from new providers in the Medicaid space to help walk alongside our families. I'm really thankful that we had responses across our whole state from folks that represent Clark and Washoe areas, as well as each of our rurals. There is significant need for regional variation. We know this, but we got a lot of great ideas on what that variation can and should look like. So we're exploring ways to build that into our contract and look forward to discussing that with you all in the months ahead. As always, concerns on provider network and provider workforce. We all feel this acutely, and we have conversations internally about this nearly every day. And so I really appreciated those that came with some ideas on how the specialty plan can help attract new providers to the market and also can support the education and training of a high quality provider workforce as well. So I'm really looking forward to incorporating some of those suggestions as well. A lot of good support on the accountability side. There are a range of mechanisms that we have to use regarding accountability for within the contract with this plan and more generally about the data and transparency about the work overall. So a lot of good detail that we'll be getting feedback on as well. And then last but certainly not least, cross-sector coordination. We all know that while Medicaid is leading the specialty plan development from the healthcare payer and procurer angle, we can't be successful unless we're closely partnering with our county partners and our sister agencies, our local government entities, and all those that are serving our youth and families that will be part of this plan on a daily basis. So I'm really thankful for the suggestions and creative feedback on ways that we can best do that, and look forward to having those direct conversations with this group in the months ahead. I do want to call out, there's some great quotes, and we just selected 3 of them that really align with today's care coordination subject. The first is really about wraparound. A provider organization shared, wraparound must be family driven and connected to the community. Families should not have to navigate the system alone. One of our county partners that provided feedback noted, we need a model that works in the rural frontier. Don't assume Clark and Washoe represent everyone, which is a crucial reminder, something I keep in mind every day. And I really want to make sure that the way that we design this plan reflects that and reflects the needs of our full state. And lastly, a youth advocacy group that responded noted, care teams must include peer support as a core service. Lived experience matters. So want to thank you all for that. Want to acknowledge the many folks on this call that did respond. If you didn't get a chance to respond, but you have feedback, don't worry. We'll be talking about all of these things in our working group meetings every month. So please know that we'll continue those conversations as well. So before we move to care coordination, I do want to call out just a quick update on where we're at, a reminder of where we're at in the timeline for the specialty plan. So again, back in May, we solicited that public comment, or actually before May, it was back in March, with the public comment due in May. Over the past 3 months, we've been really digging into that feedback, reviewing it, and incorporating it into our plan design decisions. We will be posting that feedback on our website very soon, so that way you can get a chance to take a look at that as well. The month of September, we're spending doing a deep dive on care coordination with our youth and family representatives, which we'll speak about shortly. We also have conversations with our county and sister agency partners to really get to the nitty-gritty details about how we all work together in this care coordination space to really wrap our arms around our youth and family members that will participate in this program. We've shared that there will be a bidders conference to answer some more questions and provide more detail, particularly on data regarding this plan that will be held prior to the RFP being published at this point between late October, early November. I want to call out the model that Nevada is developing is unlike any model that another state has done in the country, right? Many other states have pursued similar flavors, but this particular combination of a single integrated specialty managed care plan is not something that's been done before, which I'm really excited for and I'm really proud of, but it also reflects a net new program for the country. And so there's going to be a lot of questions on this as we go. We really hope to answer those throughout the bidders conference as well as the more formal Q&A period, but want to acknowledge and appreciate the task we have ahead of us is a really exciting one. I want to thank you all for your support in helping us develop this model that works right for our state. So with that, we will transition to our care coordination section. So I want to thank Deborah, who has joined us from the University of Connecticut Innovations Institute. They may be familiar to you all because they are part of our independent review team. Tim Marshall, our independent reviewer, is also able to join us today. And so Deborah works very closely with Tim and that team to provide us some technical assistance and really help us understand how best we can achieve the goals of our settlement with this work. So Deborah has been working closely on care management with a number of states, and I'm excited to turn it over to her to speak about that continuum of care management. And then she will be working with Matt, who will share a little bit more about how that looks within our state. So Deborah, I'll turn it over to you.
Great, thanks. Hi, nice to see all of you or be on here with all of you. I see a lot of familiar names from other work we've done in Nevada. And full disclosure, most of these slides that I'm sharing with you are from my colleagues at the National Wraparound Implementation Center, who are part of us at Innovations. So happy to share some of this and kind of lead into this work, because you have a lot of exciting things going on. So if you want to go to the next slide. So we wanted to frame up really, what are we thinking about care management? I think these terms get tossed around a lot, and we talk about care management, care coordinator, case manager, all these different terms and language. And language is just really important in everything we do. And I think that's clear by even starting this presentation about what are we naming the specialty plan, right? Words matter, language matters. And so in this case, we're talking about this continuum of care management. This is probably a little oversimplified, right? But the idea would be that you have this sort of navigation, information, referral space of care management, which is something that the specialty managed care plan can provide. And in general, you see this provided by health plans and others all the time. It's a routine part of quality care that we get from a number of providers. And lots of different folks can kind of provide this. And in this context, and in the context of the settlement agreement, we're really talking about the specialty managed care plan being able to provide this. And it's sort of a universal support. Then we get into the language that, in the settlement, we talk about intensive care coordination. And that's this middle space that the design is that the contracted care management entities would be providing that intensive care coordination. And that's sort of like a moderate tier, middle tier of care coordination, where you would expect to receive structure.
Oh, I'm seeing Deborah has frozen on my end. Are other folks seeing that as well? Yep, I'm getting some comments. So we'll wait for Deborah to. Oh, seeing some thumbs up. A flurry.
Something just happened.
No worries. I think you just cut off for a quick second, Deborah. We have you back.
Yeah, now. I'm going off camera to see if that makes a difference. My internet looks strong, so I'm not sure what happened. Sorry about that. So I think I was just saying this middle layer of intensive care coordination is for kind of that moderate level of support. For families who need more than a basic assistance, but don't need really intensive multi-system coordination that would be provided through wraparound. It's still more intensive, it's intentional, it has lower case ratios or ratios of families that are worked with. And then wraparound is a specialty kind of care coordination with a model that has a fidelity approach to it, that has evidence behind it. It's really the only evidence-informed, evidence-based model of care management that exists for kids, especially touching multiple systems. So we can go to the next slide. And so the reason, and you can click through to show this whole slide. Again, these are not my slides. They're beautifully crafted by my colleagues. But we talk about effective care management being so important and a linchpin in this work, because we know that needs are complex. Families, not through their own fault, are often not fully engaged. It's really hard to navigate systems. And it can be really overwhelming when children present with complex needs, right? There's a lot going on. And we're often we collectively, not specific to Nevada, right? Across the country, we tend not to do a great job meeting some of the basic needs, figuring out how to prioritize, juggling all the things that are up in the air. And our systems, again, across the country, tend to be siloed, right? And so sometimes we see families experiencing this terrible thing where they're pushed from one system to another. And we're trying to avoid that. We're trying to avoid unnecessary out-of-home placements and other kinds of intensive or more restrictive care when it's not what's needed. And so we have found, the evidence really shows that really good effective care management makes a difference. And this is really about 25 years of research and data that have led to this, to show that this really makes a difference for kids and families. So I'm going to pass it, I think, to Matt to speak to what is written in the settlement agreement, specifically with regard to care coordination.
Hi, for those who I haven't met before, Herdick, as Ann said, working with the team here on this behavioral health transformation project. So as Deborah mentioned, we're going to talk a little bit about what does the settlement speak to in this regard, and then I'm going to turn it back to her to get into a little bit more detail. But to kind of ground us and to get back to some of the feedback we heard in the RFI, really what is at the core of all services
Hey, Matt, just super briefly,
is that the youth who are.
Hey, Matt, sorry,
My
your
audio not
audio's getting a
working?
little wonky. Do you want to go off camera and see if that helps?
Yep.
Perfect.
All right. How's
the day
that?
the Wi-Fi went down. Yeah, no worries. That's a little better.
Apologies. All right. So as I was saying, really the goal of this is that both the child and youth and their family are at the center of all of the planning activities, and that we're really using these processes to bring together all of the other people that have an important role to play in that child and family's life and are really key to their success ongoing. And so the settlement really does drive that expectation and really layers kind of the foundation of the work ahead of us. Next slide, please. So a little bit more into the details of how the settlement has sort of driven this work. So how are families going to access care coordination services? So the settlement dictates that all children and families in the focus population must be offered wraparound facilitation. And the focus population is, broadly speaking, children that have a behavioral health disability. So that's a designation of serious emotional disturbance, serious mental illness, or substance use disorder. And then it has some other factors. We are thinking more broadly that any child that sort of meets that first metric would have access to these services and be offered that wraparound facilitation. However, we know wraparound is not appropriate for every family. They may not need that level of intensity of care, or it just may not fit into other things they have going on in their life. And that's where this kind of moderate tier fits in, and that we really want to be able to track how and why are families choosing which modality of care they'd like to receive. And then part of the group work that this group will be doing over the coming months is establishing some standards around timeliness to really make sure that these services are accessible when families need them. And in terms of who provides these services, we are utilizing a model that's been used elsewhere in the country using entities known as care management entities. And we are still defining kind of who and what those will look like, but there is some kind of general standards of what they will be doing. And so they are the ones that are going to be the providers of these two services. And we're really trying to be intentional that they're able to offer both intensive care coordination and wraparound. So as families' needs change, they're not being bounced between providers. And there's an ability for families to have some continuity in the care they receive. Then the specialty managed care plan, as we talked about earlier, they're really responsible for the coordination of youth who either don't qualify for those services or who just choose to not engage with these more intensive care coordination services for whatever reason. And then both of these entities, the CME and the managed care plan, are also going to be responsible for working with any other care coordinators and providers in the child and family's life to make sure that there really is continuity across the board. But the settlement doesn't really get at what does that look like on the ground. It gives us big picture structures and ideas, but what we're hoping to get from this group and from our future engagements is really more the tangible about the experience for the children and families. Next slide, please. Not going to spend a ton of time on here, but for folks' reference, the blue columns are sort of the definitions of the service and then the service provider at the kind of core of those services for the moderate intensive care coordination. And then the green tells a little bit more about wraparound facilitation. But from here, I'm actually going to turn it back to Deborah, who can do a deeper dive into what these two models really look like.
Great, thanks. And I'll just stay off camera and hope that my internet doesn't go again. So you'll notice that wraparound throughout is capitalized, and that's intentional because it is a model, a defined model. And so all high quality care coordination has certain elements that are consistent across. And that's what you see in the orange on the bottom, that there's a dedicated care coordinator, that you see a deliberate organization of services and supports, meaning that it's really thoughtful what goes into that child and family's plan, and what are those services and supports that are meaningful and relevant to that family to achieve their goals, the goals they define for themselves, to support continuity of care so that we don't see people sort of feel like they're dropping off from services or they can't access things. There's smooth transitions. People can access what they need when they need it. And that any high quality care coordination has this ongoing engagement, review, and adjustment process where you have formal providers, professionals, as well as natural supports, meaning all the people that the family, the child, the young person feels are important to be part of their care team, and other resources to align all those needs. So we would expect to see this in any of the care coordination, including the intensive care coordination. And then wraparound specifically is a defined process that is an ecologically based, that, you know, kind of how we think about it, that children exist within families, within communities. And we use the term families here to mean it broadly, depending on how people define their family. But that that the kids and families don't exist in isolation, right? And so they exist within schools and communities and neighborhoods, and that the care coordination takes that approach to care planning in a way that's meant to support youth really with complex needs and their families. So we can go to the next slide. The language that's used a lot right now is tiers of care coordination. And that language, I think, makes a lot of sense when we think about that nested model that we showed you a few slides ago, with what will be provided more broadly through the specialty plan, and then the intensive care coordination, and then this wraparound version. These tiers really help match better to what people need. We know that not everybody needs or wants the most kind of intensive or prescribed approach to things, and we want to make sure that the families and young people can get what they need when they need it, and by getting maybe a less intensive intervention earlier, they're able to be more successful and don't actually need that more intensive level later. So these tiers are something that we're seeing in a lot of states, a lot of communities, and we've seen it to be really effective and successful to have all of these available to kids and families. Next slide. That said, when young people access wraparound, that really does have a specific meaning to it. And like I said, we capitalize the W. Certainly in other spheres, other social services, sometimes in the adult world, the term wraparound is used generically to mean like services are wrapped around young people. And that is absolutely a lovely concept and something we should embrace. And here we mean this with a capital W. So there's a handful of things that are really important. And we talk about fidelity wraparound, meaning fidelity to the model, that we're being consistent with the model. And what we have found, what our colleagues have found over actually at this point, decades of research, is that when wraparound is not implemented with fidelity, when it doesn't, when we don't adhere to the key components of it, sometimes it is not even as good as what we would call treatment as usual. Sometimes it's even more problematic, in part probably because we have expectations raised and people are wanting things that they don't get, and so it's a problem. So fidelity and quality are really, really critical, and there's a number of fidelity standards that people who provide wraparound are trained on, they're coached on, they're supported on, and that training and coaching continues. It's not a once and done thing, but it's a continuous process with an investment in supporting really supervisors of wraparound care coordinators to do this well. There's consistency in the definition and what the practice model is, so that families and young people know what to expect. So system partners know what to expect. There are tools and materials and resources that explain what you should expect when you're going to have be involved in wraparound. Staffing ratios, they're low, right? Generally across the country, and this model, it's a care coordinator works with between 8 and 12 families. That tends to vary based on a number of factors, right? Based on the population, the distance, how much is being provided virtually, the complexity, if they have what we call sort of a mixed caseload, right? A ratio where they're working with families in multiple tiers of care coordination. There's a little variation, but generally it's 1 to 8 to 1 to 12. And then there's expectations for the workforce themselves. So when we see discrepancies in how wraparound is implemented, in terms of what staff, what care coordinators and their colleagues should be doing or not doing. That can impact skill development and implementation of the model. It can lead to frustration. It can lead to burnout. It can lead to high turnover of the care coordinators, which has a significant impact on kids and families when that turnover occurs. So if we go to the next slide, there's a lot of ways to talk about and think about wraparound, but there's 4 main phases. And you can click through to all 4. I'm not really doing my colleagues justice by not really using the transitions right here, but there's the engagement phase. And this is, really kind of a simplification of the process. But you have engagement, you have the plan creation, plan implementation, and transition. This process, though, is not necessarily perfectly linear. And care coordination is very intensive. It's relational and it's highly individualized. That is core to this model. And so the process might look different for a different child, for a different family. You might have to come back to the plan a lot more with some families based on what's going on in their lives. Transition might happen sooner for one family than another. But there's core phases, no matter who you are and what this looks like. This is how wraparound gets implemented with these 4 phases. And the care coordinators spend a really long time focusing on developing deep and trusting relationships, recognizing that families who have agreed to participate in wraparound often have had trauma, they've had burnout, they may have mistrust of systems and providers. So that becomes really, really important to help engage the family, hear their story, articulate the family vision, identify strengths. This is a strengths-based process. And then identify the needs, figure out the scheduling, figure out the process that will work best for the family. Then the goal is to facilitate team meetings that bring together all those folks we were talking about, the natural supports, the formal providers, the school personnel, child welfare folks, sometimes who may have what feels like conflicting agendas, and bring them together in one plan, one team, to create that shared plan that elevates the family's goals. The care coordinator then supports referrals and service access with follow-up to make sure the services get delivered the way they're intended, address access issues. Maybe there's an issue of transportation, of scheduling, of not getting a call back. They help with all of that. They manage documentation and reporting, really with a goal of capturing strengths and successes as well as challenges and needs. There are often crises, and so the care coordinator is there to support during and after crisis events, coordinating with your crisis providers, other providers to provide that support, updating the crisis plan so that reflects what the family needs and what works best for them. Care coordinators work very closely with supervisors to make sure that they're being consistent with fidelity to the model, identify when a plan is drifting away from that, adjust strategies to stay on track, and they do this with those low staffing ratios. The wraparound requires dedicated workforce supports, which enables the low staffing ratios, intensive supervision, ongoing coaching, and other kinds of system interventions that make this possible. So that all comes into play for wraparound. And like I said, although it looks linear, the actual process, these phases will occur for everybody, but the whole idea is you update the plan as you need to, you revise the plan when things aren't working, and you make sure the families feel supported the whole way through. Next slide. So here we're talking about intensive care coordination. And that's really kind of that moderate tier that's not as intensive as wraparound, using the language in the settlement agreement. And again, these idea of tiered care coordination becomes really important because the model I just described is incredibly intensive, and it requires meetings, at least every 30 days with frequent check-ins, perhaps weekly or more frequently than that. There's a lot of work, and not everyone needs or wants that. So if we have this more, this intensive care coordination that isn't full wraparound, right, then it gives this opportunity to intervene sooner by addressing what are moderate or significant concerns early. and really get in there, support a larger population, because the ratios are not going to be as tight for the care coordinators. There's a little less prescription in the model. There's a little more flexibility in room in this. And so it helps systems really adapt and respond to the needs of families. So I think that's it from me, and I'm going to hand it back to Matt.
Wonderful. I'm actually going to sneak in. Thank you, Deborah, for that detail. A lot of good information on those two care coordination models. And the hope is for this to be a real clear, this to be clear how it looks and feels to families, right? I think it's very easy for this to be abstract. I think we all agree with these principles in theory, but it's really a question of what does this look like in Nevada and what does this look like for our family? So I'm really excited to transition and turn it over to Jessica Gokachia, who is our co-chair and is a former provider wraparound services herself. So Jessica has been working very hard with a host of folks here behind the scenes to plan a youth and family summit. And I'd love for her to share a little bit more about what that looks like and to share kind of the details of how we'll be collecting feedback from you all in today's discussion and prior to that summit. So Jessica, I'll turn it over to you.
Okay, thank you. Can you hear me?
Yes, we can.
Yay, okay. So we are really excited that we are going to get to do a youth and family summit next month. We are doing that on September 16th, and it's going to be a virtual format. We are doing this with some key youth and family representatives and working group representatives with lived experience. And we're really grateful to have Brenna Hardner and Carly Murray. I'm hopeful that Brenna and Carly are willing to say hi and introduce themselves. They're both from Nevada PEP. Are you guys here and willing to say hi?
Yes.
Yay.
Hello.
Okay.
Thanks, Jessica. Brenna, you want to go ahead and go first?
Yeah. Hello, everyone. I'm Brenna Hartner, and I am the team facilitator with Youth Move Nevada at Nevada PEP. And I just want to say I am very honored to be the youth lead for this summit and just to work alongside all of you as we bring the youth perspectives and just making sure that every voice is heard. I'll pass it over to Carly now. Thank you.
Thanks. I'm Carly Murray. I'm the Statewide Family Network Director at Nevada PEP. I'm also a parent with lived experience. I have 2 youth with behavioral health challenges. And just really excited. I'm so glad that you guys are taking the family and youth voice and excited to bring that to the table and to help inform what our care coordination model will look like in Nevada. So thank you.
Okay, thank you guys so much. So Carly and Brenna are going to be working with us leading up to the summit and then actually at the summit. So they're going to be running some, I don't know, focus groups, if that's the right word for it, leading up to the summit to collect some data and then ensure that during the summit, the youth and family voice is actually present and that the people who are there virtually are actually feeling like they are able to be present, be heard, that nothing that is happening during the summit is stifled by, maybe the presence of the professionals that like also are there sort of by just, I don't know, by necessity because of the structure. And so we're just super grateful for your guys' participation. Right here on the slide, you can see that the objectives of this 3 hours are for us to identify the key priorities of the youth and families in the current systems, define the values and principles to guide this plan, shape the expectations for care teams, roles, communication, and accountability, and then elevate the diverse voice representing the Nevada families to influence the care coordination design. We are having this audience as the current family and youth representatives and working group representatives with lived experience. And then also members that we already have who identify as having lived experience. And so it's going to be just an interesting perspective from our members. And we're just really excited to see like what we can gather. We know that in these 1 hour meetings that we have from 4:30 to 5:30, there's a lot of information and we really can't accomplish what we need to accomplish. And so we're really hopeful in this summit, and then we will potentially have another summit with another topic to kind of be able to do this where we really can like very focus and guide this topic. So September 6th, we're going to have some pre-feedback. All the pre-feedback is going to be due so that we can sort through it, have everything ready for the summit on the 16th. We're going to share everything to all of our attendees. We can have one-on-one conversations with me, with the youth and family leads. The goal is to allow attendees basically to shape what this agenda is going to look like. And then on the 16th, we are going to have the summit. We're going to really just kind of really focus on the questions. What has helped families feel supported when we're navigating services? What gets in the way of good care coordination? Who do youth and families want on their team? And how do they want those people to communicate? And then what values should guide Nevada's care coordination program? So those are the things that we're really going to be focusing in on during those 3 hours, and in the conversations that are leading up to that Brenna and Carly are going to be having between now and then. And then in October, we're going to share all the good information that we have that's going to be guiding our care coordination plan moving forward.
Awesome. Just want to thank you, Jessica. And before we move to our full group discussion, I also want to thank Carly and Brenna. Brenna is our new, one of our new youth representatives in this forum, and I'm super appreciative of her work. Every month, she'll be bringing these topics to her youth team conversations as part of Youth Move, and then bringing feedback back to this group, which I'm just really appreciative. So, Jessica, thank you for that great rundown on what we're doing and what that looks like. I'm super thrilled. I think it's going to be the most fun 3 hour meeting that we've had in a while. So I really want to thank everyone in advance for dedicating the time to this. I know that's a big ask, but I do think this is going to be a crucial way for us to ensure that the way we're building this is reflective of the youth and families in our state. So I want to thank you three for your hard work, and also Mallory on our team as well, who's been doing yeoman's work behind the scenes to be able to pull this off. So a lot more information to come for those that are attending, and we'll talk about that at the end. But we do want to make sure that folks get a chance, every member of the working group representative group, as well as our broader members of the public, get a chance to give us some feedback going into the summit. While you may not participate in the summit itself, we'd love to hear your feedback on care coordination. So I'm excited to turn it back over to Jessica to share a couple questions, guiding questions, to get started with some discussion here in our conversation with the broader group. So Jessica, I'll turn it back to you.
Yes. Okay. So for all of you, because we all have worked right in this system, in the state. So when you are navigating in whatever insurance you have or whatever system you work with, what things have been important? What has helped your family feel supported when you're navigating services that you, well, let's just say that. Shout it out. Write it in the chat.
Yeah, we actually already have a chat. Thank you, Ashley. Always good to see you on the call. Ashley has some great questions related to alignment with current WIN efforts, as well as coordination with schools and referral pathways. So I'll take the first one, and then if Matt or Deborah or Jessica want to chime in on 2 and 3, I welcome you to do so. But also I'll just note there's a lot of these that we may not have answers to yet, right? We're in the early phases of our development. This benefit will be live in conjunction with the specialty plan in January 2027. 2027. So this is the first of many conversations, and I'm looking forward to digging into the details of each. But I appreciate, Ashley, you raised the current WIN efforts. For those that are unfamiliar, WIN is an existing wraparound program that's run by the state, and they do really excellent work in support of youth right now. And so the way that we see this wraparound service, Medicaid's role in this kind of broader landscape is to provide payment for services. The current WIN program is to be a provider of wraparound services. So the goal would be, and there's a lot of details to work out for programs like WIN to be able to supplement the funding they have by billing Medicaid as well for kids that they're serving that are Medicaid eligible. So I hope that's helpful, Ashley, on that piece. But I do really appreciate what you're raising in terms of integrating schools into community wraparound efforts, as well as those referral pathways. So open it up to our team that's been thinking about this. Any initial thoughts there, or are those items that we'd prefer to take some time to think through, and then we can come back to you, Ashley, and have perhaps a whole dedicated conversation about schools and wraparound there. So Deborah, would you be willing to share a little bit more on initial thoughts on those questions?
Sure. Yeah, absolutely. And I know my colleagues have had the pleasure of working with folks in WIN and doing work with the folks from Magellan too. I think in general, we see across the country, right, that there's sometimes it's sometimes challenging to do wraparound effectively with schools, and we also hear child welfare just across the country. Not to pick on them. I'm a 4E trained child welfare person myself. So, but I think that's what we hear, and I think it comes from a place of folks not always either understanding mandates or understanding sort of what people's schedules are and when they're available. And so, wraparound by design is meant to be flexible and work with families when they're available. So maybe that means an evening meeting, right? And then that becomes very challenging if you have school professionals who are already putting in very long days and they're, done at 5. They've been there since, whatever time in the morning, right? And so that does become challenging. And so one of the strategies that a coach would work and supervisor would work with care coordinators around is trying to problem solve and figure out how can they meet with the school personnel. Are there opportunities to get their input in a different way and coordinate during their working hours with the support and permission and engagement of the family? Like, I think there's a lot of problem solving that can be done around that, but it helps to elevate it and to know walking in that this has been a historical challenge. I think is something that's really good to put front and center. And with regard to the referral pathway, I'll just say that I think that the team is at Nevada Health Authority is working on trying to help map that out, and what are the different ways, given the focused population for the settlement agreement, what are the ways with a goal of capturing as many families who want the service to get it as possible, but recognizing again that not every family is going to even want this intensity. So what does that look like? How do you give families access and help them figure out what is the service that they actually want, versus what is just sort of seems to be available. Sometimes we have a mismatch in terms of families in any sector, not necessarily behavioral health, asking for a service or wanting a service because that's the thing we're made aware of. And so part of this work, I think the work that Anne and team are doing is also related to making sure folks know about other services and supports that are available that might meet their needs as well.
Thank you, Deborah. That's excellent. I appreciate it. And Ashley, we'd love to take you up on this offer to have further conversation, particularly about the way to integrate schools with these care coordination services. So looking forward to that. Seeing a lot of good chats, but I know Mambi has her hand up. So great, always great to see you. Thank you for joining. We'll start with you, and then we'll turn back to the questions in the chat here.
Oh, yes. So I had some comments and just feedback in reference to the question. So if I can represent
Please.
that now, or you want me to just hold on until you get there, I'm happy to do that, whatever.
Right now is great. Right now is great. Go right ahead. Yeah.
So again, my name is Miyabi Newburn Johnson. I am representing Clark County Clinical and Community Services, and really just kind of speaking to the experiences for the child welfare and juvenile delinquency population, and just reviewing the questions. I just would like to ensure that there's some consideration for the need for flexibility for the child welfare and juvenile justice population. They come with very, very large team. Most of the time, the team members are more formal supports than natural supports. So really ensuring that there's like diligence and efforts and really identifying natural supports for these youth, scheduling meetings and care coordination around times where all team members can be present and the youth feel most supported. Also understanding that the caregivers as well, they may be caring for other youth with high needs. And so ensuring that our youth are not necessarily precluded from services because they can't meet the minimum requirements. I know fidelity is key and things like that, but just really having that be really considered, that their families are just going to be unique and their needs are going to be needed, and just something where there's room to adapt around that piece. So that's one thing I really want to give some key feedback on. Just don't want our youth precluded or not being able to meet some minimum standards, because there just needs to be a lot of flexibility for our population.
Wonderful. I appreciate that, Miambi. I think that's an excellent point. And that really speaks to the need for wraparound to reflect the needs of that child and family team, especially when that child and family team has a lot more formal supports in it, right? And how do we ensure that the expectations that we're setting both meet the clinical fidelity of the high fidelity wraparound model, but also really do serve where that youth is at in their journey, and not setting expectations that are just not possible for them to meet. So really appreciate that. Well noted, and something that we've been thinking about as well. Care coordination for each of the kind of unique subsets of our population is something we need to spend a lot of time on. So thank you for calling that out. Anything you want to follow up on there?
Yes, and I would also like to add, if it hasn't been considered already, or any youth that you could add that have lived experience from the child welfare and juvenile justice population, I would recommend an invitation to them at the summit and really have them at the table. We have many youth that have aged out of the system with extended foster care, our step-up programs, as well as our independent living programs. And I would just want their voice to be heard as well, so that they can weigh in on their own personal experiences.
Yeah, thank you for that. I appreciate it. Brenna, I'm sure that's something that you've been thinking about as well, and maybe part of Youth Move. So welcome you if you want to chime in here, or if you want to just connect with me on Be Offline. Melorine can connect you too. But I think that's an excellent point, and we absolutely need youth, particularly the youth that have aged out of the system or have a lot of years of experience with it and can reflect on that and share with us. I think would be really excellent. So would love for us to connect on that offline. Anything you want to add there though, Brenna?
No, I was just gonna put in the chat that yes, let's definitely connect offline. But Miambi, you bring up a really great point, and especially just making sure like youth, especially youth who are underrepresented, need to be brought to the table and have their voice heard. So thank you for bringing that up.
Absolutely. All right, I'm going to turn to a couple questions in the chat here. Appreciate, Britt, you sharing the challenges that your family has faced in terms of access, particularly with the turnover and not having those warm transitions. So would love to, if you want to come up, you're welcome to share more about that, but I also just want to thank you for sharing this here in the chat. That is something that will be really crucial. We know staff turnover in any provider or any industry is inevitable, but there's ways that we can handle it that are very sensitive, particularly recognizing our population, those transitions may be even harder for them. And so we need to do really be very transparent and proactive and thoughtful about the way that happens. So thank you for sharing that. I appreciate it. Azraela, it's great to see you. Welcome. Glad you joined. We actually do not have a rate for the service set yet. That's because it's going to be net new to the state. And so we're trying to figure out the right way to define it. And that's actually probably something we'll bring to this group in terms of the different types of quality designs that we build within this model. So I'm looking forward to feedback from the group and having some dedicated conversations with particularly folks that are providing wraparound right now. So great question. More to come on that. Beverly Hart, great to see you as well. Tiered coordination, yes, it is not new to Nevada. The Connect Nevada program that Magellan is doing offers high fidelity wraparound as well as intensive care coordination. WIN offers high fidelity wraparound right now. And I know there's actually a host of others out there in the state. So I think what's really helpful is we're not trying to do something net new here. What is new is that Medicaid will be able to pay for it. And we are setting the Medicaid policy in alignment with both the settlement and also feedback from you all. So hope that answers your question, and I appreciate you calling that out. Those are the folks that we are communicating with and excited to continue to learn from as we figure out the right way to do this. Sherilyn, as always, appreciate your question about how we support our hospitals. Yes, care coordination with hospitals is crucial, and we recognize, particularly in these acute moments or crisis moments, that care coordination is even more important. The settlement actually has some really helpful guidelines that regard those care transitions from a hospital setting as well as a PRTF setting. So we'll reflect that as part of our care coordination expectations. But I think we're going to need to spend some time with this group as well, figuring out exactly how do we set those expectations in our policy that align with what we need, given what a challenging moment that could be for youth and families. So thank you for calling that out, and I'd love to pick your brain on that as well as we get into that section. Ashley, we already chatted. I can't wait for more. And Karen, good question. At risk will be defined as youth that reach a particular threshold on the to be defined screening tool. And stay tuned for more summit conversations with providers on that later this fall. But your question is a good one about what care coordination level would at risk youth have access to. That's actually not been defined yet. I think what's clear is we will have these various tiers. And what we need to figure out is how to balance provider capacity with also the needs of our population. So if you have particular recommendation or preferences there, we'd love to hear it. That's something that we'll be thinking through in the months ahead. So no clear answer or final answer on that one yet. Good question. And thank you, Catherine. Wonderful. Glad to have you here. And we recognize there's probably a lot of wraparound providers on this call right now. So we appreciate your patience as we're explaining what it is that you do on a daily basis. And we're really appreciative of all that work. So if you want to come off mute and share any reflections or learnings from your programs, we are, as always, very eager to hear those. Yeah, Sherilyn.
I just had another question too, on the staffing ratio, kind of concerned about our rural and frontier regions, because that's my passion. That 1 to 8 to 12, I'm really curious as how that's going to work out in the rural and frontier regions when we are lacking staffing as it is for services today. So I'd love to hear what that solution is going to look like. I know it may take some time to do that, but and we're here to talk about that, but love to see what that solution is going to look like.
Absolutely. I'd love to get your creative ideas as always on that too. That's always a challenge, right? And I think the provider workforce development is something that keeps me up at night. And I know for all of us on the call, this is not something that is, we'll be able to immediately have access in every corner of our state, right? We need to spend some really dedicated time training and growing our provider staff. I'd love, Deborah, if you have any thoughts on that to share from your experience with other states that may have faced some challenges with rural or frontier areas, and if you have any ideas that you'd want to share with the group here as well.
I don't. I know that this comes up a lot. My colleagues certainly could answer this a little bit better. They've seen it, and I think Oklahoma and a few other states have figured out a few ways to do it, including use of technology, and thinking about the role technology can play, recognizing that there's access issues with technology as well. So I think that is an ongoing issue, for sure. But I do think that one of the things about care coordination is it, depending on how the state decides to define it, it does not inherently require like a master's degree or an advanced license as much as it requires completing training and coaching and ongoing certification. And that in and of itself tends to help make it more accessible in more communities, because we're not requiring the same level of like clinical licensure that you might with other services and supports. So that is one thing that I think has helped, but I am not going to pretend it's not an issue and a challenge. And I'm going to probably defer to my colleagues who are part of the National Wraparound Implementation Center who could answer that better, and happy to like connect and have them follow up too.
Thank you, Deborah. Yeah. Karen's question here, is it required that an intensive care coordinator be a wraparound facilitator? Deborah, what's your thoughts there? I have an answer, but I don't want to overstep. So please go ahead.
The way it's defined in the settlement agreement, I believe the answer is no. I think there's an opportunity to potentially do cross training and to have that. That's certainly one option to help with workforce issues. But the way it's defined in the settlement agreement does not appear to require that. And I saw there was a comment about focus, and I would say that is, I was just going to throw a note in the chat that focus tends to be called a moderate care coordination, and for the purpose of the settlement agreement, it really lines up nicely with intensive care coordination. So for those of you who are familiar with focus, focus could be the model, could be a model, whatever the state decides to do, for intensive care coordination. And to those of you who are familiar with focus, know that a focus care coordinator is not necessarily somebody who is trained as a wraparound facilitator or care coordinator. That standard is a little bit different. So kind of pulling that apart and teasing that apart is helpful in this.
Yeah, thank you, Deborah. And I will say, if your head is spinning with all of the definitions here on care coordination and case management and intensive care coordination, we actually will plan to make some sort of one-pager kind of summary of all those definitions, particularly once those are aligning with our policy. I know it's really important. The language really matters here, and they all mean just slightly unique flavors of similar things. We want to make sure it's very clear for all of us what we're talking about. So I really appreciate that question, and we will continue to share those and really try to be very clear when we're communicating about exactly what we're talking about there. So thank you. All right. We're getting close to the bottom of the hour here. Jessica, is there anything else you want to add in closing? I really appreciate this discussion.
Yeah, I think that we have like 3 minutes, and I am curious. The question that I do think is really important, I mean, they're all very important questions, but from your guys' perspective, what gets in the way of good care coordination? And I know that's a very loaded question with 3 minutes, but for our families, for the kids who we work with, for our kids, what gets in the way? Or who gets in the way?
Seeing some good comments in the chat here. Thank you, Elena and Grace. Good to see you here, Grace. Yeah, I think that's I really appreciate you calling that out, Jessica. That is the question, the crucial question. And I'd love for folks that have lived experience here to really reflect on that and share that in the pre-read and preparation. I think it's crucial. We also welcome folks to drop it in the chat right now as we close, and we will be documenting all of these and bringing them to that group. So I really appreciate this full list, because there are some significant barriers, and I think for each of them we can think creatively about how to design a model that at least begins to address them. So I really appreciate that. All right. Thank you, Jessica, for your facilitation and for walking us through the preparation for the summit. In wrap up, related to this summit, for those that will be joining us on September 16th, stay tuned for email information. We'll be sending that calendar hold if you haven't gotten it already, as well as that pre-reflection questions for you to share. Want to again thank Carly and Brenna and Jessica for their hard work to really solicit feedback from a host of folks to then bring to this smaller group discussion. And we're excited for those that will be joining us in October to hear more about it. So for all working group members, we again welcome your feedback and via email, as always, at our inbox, which you'll see listed there. And as a reminder, submit your vote for the specialty plan name. We'll drop that link in the chat one more time for folks that may have joined us a bit later. But as a reminder, I think the key takeaways on this discussion: the final plan design must reflect our settlement compliance and lived experience of our youth and family members. And I think these really do align nicely, and we're eager to get into those details of what that looks and feels like in our summit. And we really appreciate you all taking the time to provide that input. I know these are often really sensitive and challenging conversations to have, and we take that seriously and are very honored that you all are willing to share that with us. So thank you. As always, we look forward to our next discussion, which this time will happen as a full group on October 9th. As a reminder, that Youth and Family Summit is going to take place in place of our September meeting. So the broader group, we look forward to seeing you all back here in October. But before we close, as always, we will have public comment. As a reminder, please say your name on the record so we can make sure to get that noted. But as our normal disclosure, no action may be taken upon a matter raised under public comment period unless it's been included as an agenda item. Comments are limited to 3 minutes per person. And again, please state your name and raise your hand so we can go ahead and call on you here.
Holland Anderson.
Yeah, Holland, go ahead.
Holland Anderson. I just wanted to give my name.
Oh, wonderful.
Thank you.
And go ahead. Who are you with, Holland?
I'm with United Healthcare.
Great. Thank you, Holland.
Thank
Welcome.
you.
All right. Seeing no other public comments, we will close right here. Oh, before we go, Sherilyn, right before the buzzer. Well done. Go ahead.
Sorry, Jan. So as I'm sitting here listening to these conversations and we're looking at that GOJ report and we're trying to follow, those guidelines and things like that, I'm wondering if there's any kind of legislation that can come out of this to move for next session. If there's things that you can think of, maybe we could get together and talk about that. Board has a BDR. I know they're looking at that children's behavioral health and what that looks like. So I see Shayla's on here, but just wanted to pick your brain a little. Maybe there's something that the board can help with moving forward when it comes to our youth behavioral health.
Yeah, thank you for that, Sherilyn. I appreciate it. As always, we appreciate our partnership with the board and happy to provide any technical assistance on those conversations. I will note we include a lot of children's behavioral health items as part of our agency's budget request, and we anticipate doing the same to really think through the right resources and funding that we need at that point in the process as part of our budget request for the upcoming cycle. But we recognize that many others would be interested in legislative pursuits and happy to provide that technical assistance there as well. So thank you for that, Sherilyn. I appreciate it.
Thank you, Jan.
Great. All right. Seeing no other comments, we will adjourn. Thank you again for the time. I truly appreciate it. And I hope you all have a lovely rest of your afternoon and a great first week back to school for those for whom this is back to school. So thank you all. And we look forward to seeing you in September for the summit or October for our next full group meeting. Take care.